So for audience, it will be a different link. So
Okay, right.
yes.
Can you mute everyone else and just start off? So I'll start off and then I hand it over to Rajesh. Okay. Good evening, everyone. Thank you very much for joining in. This is a new exciting era of immunotherapy in bladder cancer. So we have got both the immunotherapy with respect to muscle invasive bladder cancer as well as non-muscle invasive bladder cancer. And I don't know the rationale, but I think they have named them after big rivers. So the first one was the Niagara, which was the MIBC one, and the more recent one is the Potomac. So they're going back to USA to name it as Potomac. So we'll start off with the non-muscle invasive bladder cancer, which is what have been the new updates with respect to NMIBC. And I'm going to request Dr. Rajesh అంత పెద్ద పెట్టుకున్నా అన్ని రాజేష్ కుమార్ రెడ్డి అడపాల రాజేష్ అడపాల consultant uro-oncologist at AINU Banjara Hills to start off with the recent updates in NMIBC. Over to you, Rajesh. You are muted.
Thanks for the introduction, sir. Good evening, everyone. Warm greetings from AINU Hyderabad. I'm going to discuss on recent updates on NMIBC treatment, specifically focusing on Potomac trial. As all of us know, non-muscle invasive bladder cancer, which includes carcinoma in situ, TA disease that is confined to mucosa, and T1 that is invading into the lamina propria. 75% of the cases are at the time of diagnosis are non-muscle invasive bladder cancer. And among the non-muscle invasive bladder cancers, 45% of the patients are diagnosed to have high-risk non-muscle invasive bladder cancer. And it's been 35 years ever since BCG was started along with the maintenance. But still we are following the same protocol, intravesical BCG induction for 6 cycles, that is followed by maintenance for 3 years as per the LAMPS protocol. So there are certain issues with the BCG, especially in Indian scenario. So number one is the BCG toxicity. And even though local symptoms are very high, up to 95% it can go. And there are few, systemic complications which can lead to, disastrous event to the patient, which requires antitubercular treatment and steroids. The second problem is BCG unresponsive disease, which is very high. It is around 30 to 40% in just 2 years of starting BCG. So what is the best treatment possible? There are 2 treatments available, radical cystectomy and bladder preservation strategies. However, any treatment other than radical cystectomy must be considered oncologically inferior in patients with BCG unresponsive disease. And cancer specific, the reason why the cancer specific survival after early radical cystectomy is approximately 80 to 90%. Even all the guidelines recommends to go for radical cystectomy in case of BCG unresponsive disease. So a radical cystectomy in NMIBC scenario, mainly classified as follows. The first one is immediately at the time of diagnosis. If you do radical cystectomy, that is called immediate cystectomy. You start BCG, then patient developed BCG unresponsive disease. You do radical cystectomy, that is called early radical cystectomy. After BCG unresponsive disease, you gave a salvage intravesical therapies. Then patient developed reoccurrence or progression. Then you do cystectomy, that is called late cystectomy. There is something called too late cystectomy. Patient has already developed muscle invasive bladder cancer. That is too late radical. Why is it called too late cystectomy? Only 50% of the patients undergoing radical cystectomy after progression to muscle invasive bladder cancer will survive at 5 years. So it is always better to go for immediate cystectomy rather than late or too late radical cystectomy. So better to do cystectomy at the time of diagnosis. But there is a problem with the immediate radical cystectomy. The radical cystectomy has a lot of surgical morbidity and rarely mortality, and it definitely affects quality of life. And there are the fitness issues because bladder cancer usually a disease of elderly. So these disadvantages with the radical cystectomy we cannot deny. So this is definitely one of the unmet needs in non-muscle invasive bladder cancer. So what is the need of the hour? So we need something which is oncologically superior at the same time to preserve the bladder. There are various drugs have been developed to delay or remove the need for radical cystectomy for NMIBC. The first and foremost thing is immunotherapy, targeted therapy, and there are various vaccines like Catstiladin and Cretostigmogene. Let us focus on immunotherapies in non-muscle invasive bladder cancer. What is the rationale? It's already proven beyond the doubts that high rate of tumor mutations in the bladder cancer, which can result in environment which is suitable for immunotherapy. And on top of that, we have a BCG, which has got a initial proof of principle that bladder cancer can be treated with immunotherapy. Initially, Keynote 057, that was for pembrolizumab approved for BCG unresponsive disease. With a good complete response, it's around 57% at the end of 12 months and 40% at the end of 3 years. So based on these results, FDA approved the use of pembrolizumab in NMIBC, that is BCG unresponsive disease. What about BCG naive? We already discussed that doing immediate treatment after diagnosed to have a high risk NMIBC. So here are few trials, phase 3 clinical trials, where they examined the role of immunotherapy in BCG naive setting. The most important thing is Potomac trial, the Alban trial, another one is CREST trial, and pembrolizumab Keynote 676. Now I'll start with Potomac trial. That's a durvalumab in combination with BCG for BCG naive high risk NMIBC. What is durvalumab? Durvalumab is a PD-L1 inhibitor, which is kind of immune checkpoint inhibitor. So the study design of Potomac trial, it is a randomized open label phase 3 trial where there are 3 arms. The first arm, durvalumab and BCG induction as well as maintenance. The second arm, durvalumab and BCG induction only. And third one, BCG induction as well as maintenance. This is the study design. All the BCG naive high-risk patients are included in the study, including T1 disease, high-grade disease, carcinoma in situ, and they are equally randomized into 3 arms, as we already discussed. In first arm, that is the study arm, durvalumab and BCG, which was given the induction as well as maintenance. In durvalumab, that is 1500 mg intravenous once in 4 weeks for 13 cycles, that is for 1 year. And BCG induction weekly for 6 weeks. And BCG maintenance, unlike as per the LAMPS protocol, the maintenance is for 3 years. Most of the patients don't tolerate. However, here they have restricted the maintenance to 24 months. In second arm, that is durvalumab and BCG induction only, that is durvalumab as per the first arm, and BCG induction only for 6 weeks, once a week for 6 weeks. And third one is, as usual, BCG induction and maintenance. These are the primary endpoint. The first and foremost primary endpoint is the disease-free survival, because recurrence is the most important nagging thing in non-muscle invasive bladder cancer. And survival, the overall mortality is not an immediate threat. So the disease-free survival, which is compared with the control arm, that is BCG induction as well as maintenance arm. The secondary endpoints are disease-free survival with durvalumab plus BCG induction only versus BCG induction plus maintenance, and disease-free survival at 24 months, complete response rate at the end of 6 months. And other secondary points are overall survival, safety issues, and quality of life. So what is the definition of disease-free survival? So I'll go later. And one most important thing to be remembered, for each dose of BCG, patients received 1 vial of TICE strain of BCG, which contains 1 to 8 into 10 to the power of 8 colony forming units. Here, this is 1 to 8 into 10 to the power of 8 colony. That means they have used only 1 vial. and otherwise they have used equivalent dose of local standard BCG strain. So vis-a-vis where we use here in India, we use 80 milligrams, that is 2 vials. Each vial contains 1 to 19 into 10 to the power of 8 colony forming units. This is the difference. So this is the patient's distribution. 1,350 patients were enrolled and assessed for the eligibility. However, among them only 1,018 patients were eligible for the study and randomized. All the patients were randomized equally into all the groups. And at the end of the 330 in first arm, the study arm, 336 patients started the treatment. Among them, only 180 patients completed the treatment. 156 did not. So the reason being is adverse events in 61 patients. Most of the patients had the adverse events is the reason for incompletion of the treatment. Whereas in the control arm, again, the side effects is the reasons for adverse events are the reason for the incompletion of the treatment. And in the control arm, only 182 patients completed the treatment, 157 did not. It is almost similar to the study arm. Whereas in only in the induction BCG, 38%, very less, like relatively, the most of the patients completed the treatment. Only 98 patients, when compared with the other groups, did not complete the treatments, and adverse events are relatively less. So probably is BCG the reason, because here BCG maintenance was given, here BCG maintenance was given. However, in the induction arm, BCG maintenance was avoided. Anyway, let us go through the dissect further. This is the demographic and disease characteristics are balanced, equally distributed, including age, sex of the patient, and region. One thing to remember, Asian population 18%, 19%, and 18%, respectively. This is mostly done in Europe. Few centers in Russia and few centers in Australia were enrolled. And Asian patients around 18% or approximately around 20% in each arm. And no US population. It was not done to US. It's being done with another name that is called Potosco trial or something. Not Potomac trial. US population were not included. And the performance status, smoking, current former, never, all are equally distributed. And disease status, here one most important thing is T1 disease, almost like maximum number of the invasive disease, that is lamina propria invasion, T1 disease. And again, another high risk pathological features, carcinoma in situ is seen in 37% of the patients. And PD-L1 testing was also done. And the PD-L1 testing was the positive in almost 20 to 25% of the patients. Now, our primary endpoint, which is a disease-free survival. What is disease-free survival? The definition of disease-free survival in this case, the high-risk recurrences in terms of high-grade reoccurrence of the high-grade disease or the carcinoma in situ or T1 disease or muscle invasion or death. So this includes disease-free survival. Here, the most important we can the observation we can see is the curves are separating very early, and we can see the sustained response till almost for 5 years, 60 months. It is almost for 5 years follow-up. Curves separated early and keep on separating at the end of 5 years. So early response as well as sustained response was noted with durvalumab along with BCG induction as well as maintenance. Here we can see in BCG, the control arm, 98 patients had the events. However, in the durvalumab arm, 67 patients had the events. So this is the hazard ratio. Hazard ratio is 0.68. So that means there is a 32% of the risk reduction at the median follow-up of 60.7 months. That is approximately 5 years. Second thing, across the subgroup analysis, the same results were found, be it age, region, performance, smoking status, BCG strain, and there are few outliers here. Here one is the sex. There is only one difference, but that is not statistically significant. We can ignore it. And second outlier is carcinoma in situ. There is not much difference between uh, adding durvalumab to the BCG induction as well as maintenance. So these two are the important findings here. And when you compare with the PDL1 status also, if patient has got high PDL1 status, the response is even better. So this is another thing. And there is not much difference between the Thai strain and other strains. Other strains, what are the strains used? We don't know. Overall survival in BCG arm, there were 52 deaths. When compared to durvalumab, it is 41 deaths. However, it is not clinically that much significant. Curves are not separating much at the end of 5 years. But we don't have any, probably this is not powered enough. How many patients had the non-muscle invasive recurrences? How many patients had the muscle invasive recurrence? How many patients had the metastatic? So this information we don't have. Quality of life, and most of the patients could tolerate the immunotherapy. Not much significant deviation in the quality of life. And when compared, when we see the adverse events, treatment-related adverse events are more in durvalumab group when compared to the BCG. And serious adverse events are also more when in durvalumab group when compared to BCG. And luckily, there was no death because of the treatment. And the adverse events related to durvalumab is more, almost like possibly related to durvalumab and related to BCG, both are equal. Here we can see both are almost equal. So, and here in this slide we can see, so whatever we are worrying about the local symptoms with the BCG, adding durvalumab, our BCG cystitis is not potentiated. Here we can see 37 and 36, not much difference, especially dysuria, hematuria, and pollakiuria. Pollakiuria means daytime frequency. Urinary tract infection, cystitis, pyrexia, these are almost same. However, immune-related side effects, by default, more for durvalumab group. In conclusion, combination of durvalumab along with the BCG had a definite disease-free survival benefit, that is 32% reduction in the risk of disease-free survival. And DFS benefit is early as well as sustained at the end of 5 years. Overall survival, not much difference. The drug is safety profile is manageable. There is another study, the CREST study. The protocol is almost similar with durvalumab. Here the drug is sesanlimab. Sesanlimab is a subcutaneous injection. One thing to remember, sesanlimab is a subcutaneous injection. And here also it is the division is almost similar to Potomac trial. And so one important thing to remember, sesanlimab is a subcutaneous injection and that is given for 2 years, 25 cycles, whereas durvalumab was given intravenous and given for 1 year. That is one important difference. Yeah. So the primary endpoint, there is definitely disease-free survival benefit. Unlike Potomac trial, where durvalumab did not have much benefit on the carcinoma in situ. However, even with the carcinoma in situ, the sesanlimab had the better disease-free survival. So these are the differences between the Potomac and CREST. Sesanlimab is subcutaneous injection up to 25 cycles and similar disease-free survival benefit. However, median follow-up is 36 months in CREST trial, whereas in Potomac trial, it is a bit more prolonged, that is 5 years. And immune-related adverse events are also more in sesanlimab. Probably they have given for long, like 2 years. There is another study, that is Alban study. It's a negative trial where they have given atazolumab, which was found not much effective. In summary, there are various emerging treatments, including immunotherapy, targeted therapy, and gene therapy. In Potomac trial, durvalumab plus BCG reduced BCG induction as well as maintenance, reduced the disease risk when compared to BCG alone, 32% relative reduction. In CREST, again 32% risk reduction, that is sesanlimab. And both trials enrolled BCG naive patients, high risk disease, and safety profiles are the manageable in both the studies, and definitely it has got the practice impact. So, however, it is not approved. FDA approval is awaited. Even India approval is awaited, and we need a little more long-term data, and cost is definitely an issue, especially in India. With this, I would like to conclude my discussion. Thank you.
Thank you very much, Rajesh. What I would request is please do hang around for the panel because you
Sure,
will
sir.
be the expert. If there are questions which we can't answer, then we'll come back to you.
Oh, sure, sir. Definitely,
Yeah.
sir.
Okay. Is Raghavan there?
At your service, sir.
Okay. Looking smart as usual. Go ahead.
Just pretending to be that way.
Okay. We'll start off.
So I'm just 1 second, Sanjay.
So it would be the same, Raghu, if you can hang around for the panel discussion, please, after your talk.
Okay. Okay. Thanks, Sanjay, and good evening, all. There was a lot of learning for me as well. Had superficially read Niagara a while ago. It was an opportunity to read more in detail. So, being an academic forum, I'm going to share my thoughts. The slides are from AstraZeneca, but I'm going to share my thoughts and ask your eyes to look at things which I thought was interesting as well. So, this is all about IO in muscle invasive bladder cancer. We all know, all of us are we all know that muscle invasive bladder cancer is what we are looking at today's topic. We are chemotherapy, and we all know that the standard of care is to give neoadjuvant therapy and then do surgery. Now, the first thing that happened in the last few years, after many years of ruling the roost with GC, suddenly the Vesper trial told us that, hang on, there is probably a better option than GC, which gave an advantage in the OS and disease-free survival. The problem with the Vesper trial, there are lots of comments on that. You can go and read about it, but problem is that it is a much more intense regime compared to GC, and it is a slight mismatch, a 6-cycle versus 4-cycle as well. But nonetheless,
Raghu, sorry.
Vesper
Do you want to just
showed that there.
stop your video because your voice is skipping? I think the bandwidth is an issue. So if you just stop your video but continue with the other parts. Your voice is skipping. Yeah, that's good.
Is it better now?
Yeah, this is a
Yeah,
better photo as well.
So, yeah, thanks. So people know that this is the way I exist around. So coming to Vesper trial, we know that betterment in the progression-free survival and OS benefit. And so keep in mind that just cystectomy vis-a-vis neoadjuvant with cystectomy gave about 5% advantage, and Vesper gave that extra 4% advantage as well. So we are looking at good advantage here. Now, but we also have the challenge of patients who are cis ineligible and the complications of cis as well. In this context, all is that there are two questions that, as far as I could see, which are there. Can we improve the survival in any other way? Just by giving that chemotherapy, we are getting about 5% betterment. But that comes with a lot of side effects. And if we add something else, even those what is this ineligible, or can be enrolled and given that extra margin of benefit. So on this basis, the trial was launched. It's a simple design which gave during the continued with comparative arm is the GC, which is the standard we all know for a while. Here, looked at the pathologically complete response, the OS, and event-free survival. Even so are considered as here in this as event included progression of the disease, recurrence after ASI, the deferment of surgical date also is deemed as an event as well, and death. So the trial has been done very well. So let us not doubt that the conducted very robustly. So what is the, so we always look at the next thing you need. So those been taken up with modified dose of cis and along with the durvalumab as well, and the modified dose of cis on the comparative arm. And patients who had no positive disease on the preoperative scans. Also to note is the PD-L1, 75% on both arms had a good PD-L1 expression and about 25% didn't have it. Please park this here because you are going to see some interesting differences there as well. So then we go into the endpoints where we look at EFS, and obviously as expected the durvalumab arm has shown a very significant difference in for cystectomy patients. It became 59 with just GC and with just GC, but it became 67 when you add.
Raghu, the slides are not moving.
And there is separation of the curve at 5 years as well. That is for the EFS. And the OS also shows distinct difference and separation of curve. So which means that from moving the survival from about 50-55 to nearly 75 with GC, we have moved it to 82. That is about another 7+% advantage we are getting with adding durvalumab in the regime. Okay. The next thing that the trial coordinators have looked at is the pathological complete response, PCR. So don't be confused about these 2 points. See the right side column. Reanalysis April 2024 matters a lot. So the durvalumab arm had nearly 40% pathological complete response, vis-a-vis in the GC arm, the standard one-fourth of the patient had pathological complete response. Now, the comment is whether this pathological complete response will translate to overall survival or not. That is a question which remains unanswered. But nonetheless, we also know that OS also has been better with the GC plus Durva arm. Now, this is very important to understand that in the patients who have PCRs compared to patients who didn't have PCRs. So this slide shows the PCR versus non-PCR, that is pathological complete response patients. If you look at that, the PCR patients had the best EFS, best. Nearly 92% of them went through for 5 years without a problem. So looks like if you give GC with Durva and you get a PCR, it's likely that you're going to live very nicely. That's the take-home message here. And even in the comparative arm, when there is a PCR, they also do well. But the differences are always about 7% between the two arms. Okay. Exactly same findings in the OS as well. PCR versus non-PCR group. OS patients have near 100% survival. Now, the risk of, that is DFS, disease-free survival. If you look at the disease-free survival, once again, you can see that if you add durvalumab to the overall scheme, you are going to get a 31% relative risk reduction, not an absolute, with the arm when you add durvalumab to the regime. Okay, now the most important question that we all started with. Remember my point about creatinine clearance and borderline patients who we will deem as is ineligible. Even in those patients with borderline renal functions where creatinine clearance is only 40 to 60, you can see that there is a difference between these two groups when it comes to EFS, but the survival itself is much lower compared to the main group. The safety profile is very decent, no major side effects. But if you look at the patients who had immune-mediated reaction, as expected, the Durva arm had immune-mediated responses. Roughly look at this, AE of any cause is 99 and grade 3, grade 4 is 76 patient. And the serious adverse events with the Durva is 66. So that is meaning giving immunotherapy is not 100% safe. You are going to have patients with side effects which you should be capable of managing before giving these drugs. If you look at, okay, now the question that comes to us is, over a long period of time, we never gave adjuvant therapy after RC. Now, Durva talks about adjuvant therapy after RC using immune checkpoint inhibitors. What other trials are available which have been before this, which talks about the same concept as in adjuvant immunotherapy? Now, we have 3 trials looking at all the main drugs, the Nivo, Pembro, and the Ates. So you have the Checkmate 274, Ambassador, and Imvigor. And you can see that the median DFS has been very similar across board as well. That is 22, 29, 19. So roughly in the 20s, you're going to find a DFS for these patients. Now, is Durva better than these things? Answer is yes. We are much better, but comparing, see, once again, the problem is we are comparing apple and oranges, where it is a GC with Durva plus Durva post-op. Here, we are just comparing just an adjuvant immunotherapy. We cannot compare A and B, but nonetheless, we know that adding immune checkpoint inhibitors does definitely have a positive impact on the survival and comes with the cost of grade 3, grade 4 adverse events as well. Please keep that in mind. Immune checkpoint inhibitors are not piece of cake. They have their quota of problems as well. Then they have discussed a bit about the other trials, Nivo and Invigor as well, and Ambassador as well. Very similar statistics. They give an extra advantage of about 22 months. Now, I'm going to move and show what has happened because of this trial. It has now come in all the guidelines. EAU has definitely said that sandwich therapy with GC with Durva prior to cystectomy and Durva after cystectomy should be considered. Same in NCCN as well. It has been recommended there. So, and in the adjuvant setting, we all know that Durva is a part of the sandwich therapy, but we can consider Nivo and Pembro as well in an adjuvant setting in patients who did not get any preoperative treatment. But the sandwich therapy is going to be the standard of care in future. Now, I'm going to go back and show you some points which was slightly intriguing for me. I'm just going to look at, Sanjay, you're going to allow me to share a different screen for 1 minute because these are important points to be discussed as well. I'm going to complete this and then I'm going to, okay, stop share. And I'm going to, okay, full text. Can you guys see this? Can I share this for a second if you guys don't mind?
You can share, but we can just see your smiling face.
Oh, thanks. Just give me a minute. I'll make it happen. Here, yeah, full text.
Okay.
Okay. What I want you guys to look at are these things. Yeah. This is the forest plot. Can you guys see the forest plot now?
Yeah.
Yeah. So please look at this. This is Durva versus comparison, and this is the forest plot which is showing all the data points. We all know that tight lines means that they are good. Look at all the tight lines, and also equally important, look at the loose lines as well. First thing you need to see is that when age is less than 65, looks like you're going to do well, right? Second point is this point, Asia. The number of patients recruited from Asia is not very high, 34 out of 151. In both arms, about 30 patients have come from Asia. And it has not shown much of differences in that cohort, but it is not designed to pick up the problem there. Nonetheless, we can see some trends here. Please keep that. That's what I wanted to show as well. Now, and we are in Asia, by the way. Then creatinine clearance. When the creatinine clearance is high, you can see that the response is beautiful and the line is short with a very, very good forest plot finding. Vis-a-vis when the creatinine clearance is borderline, even though it reaches statistical significance, it is bit borderline. Thirdly, look at the PDL1 expression. When you have a high expression, excellent response, as you can see. But when you have a low or none, the line is wide, meaning it probably is working even in the low or none.
Raghu, it's the
but we
other
are
way
not
around.
sure.
Durvalumab is better even in low or none.
Even in that, but the line is
It's
longer.
wider, but it is further
It is still